Hello, welcome to Webinar 3 in our series, Supporting Children Affected by Prenatal Substance Exposure. My name is Brenda Farrell, and I am a project analyst at the Abandoned Infants Assistance Resource Center. Today's webinar is titled Strengthening the Parent-Child Attachment in Families Affected by Substance Use. It is presented by Karen Gould and Beth Marron. Karen is the Director of Early Childhood Trauma Services at the Institute for Health and Recovery in Cambridge, Mass. Her work focuses on issues of traumatic stress in young children whose parents are in recovery from substance use and/or co-occurring disorders. Karen is licensed as a clinical social worker in Massachusetts. She has experience providing mental health services with children, adolescents, and families. In addition to experience with program development and training, she has a private practice and consults to the Boston and Lynn Public Schools. Beth is a child clinician at the Institute for Health and Recovery. She delivers attachment-based interventions for infants, children, and parents. She has practiced in outpatient and residential substance abuse treatment settings and at a child mental health clinic. She has also provided technical assistance training to practitioners on clinical interventions. Besides her work at the Institute for Health and Recovery, Beth is a part-time staff member of the Rice Center for Young Children and Families at the Boston Institute for Psychotherapy. Before we start, I'd like to remind you that you can ask questions using the chat feature in the lower left portion of your screen. We will leave some time at the end of the presentation for questions, but please feel free to chat your questions in at any point. Questions will be answered in the order in which they are received. And now, I'd like to turn it over to Karen and Beth. Thank you so much for being here with us today.
Hello, and thank you so much for having me. Today we're going to be talking about strategies for strengthening the parent-child attachment in families affected by substance use. We thought we would begin by briefly discussing attachment and what we know happens when it goes well as barriers that arise, particularly in families where there is substance use. So what we do know is that attachment is it's a partnership between a parent and a child. It's not one specific person in the dyad. It's a pattern of interactions. So what we do know is it's a pattern of interactions over time that do create a sense of trust and security in an infant or a child. I should say a pattern of interactions over time that creates a sense of whatever type of attachment. And as I mentioned before, it's not just one way, it's a dyad. So on the part of the parent, it requires the parent to be sensitive, contingent, available. And on the infant side, it really requires the infant to be able to show his or her needs to the parent, to give cues clearly, and to develop flexibility and ability to cooperate in the efforts to regulate with the parent. And as Dr. Winnicott said, there's no such thing as a baby, there's a baby and someone. And also another way to look at it is Diana Fascia said, we seek to know that we are held in the mind and heart of one another. And I think one of the ways that we do know that we are held in the mind and heart of someone else is that they know who we are. And I think one of the things that we know happens when there's separation due to substance use is that parents and children don't have the opportunity actually to get to know each other, or when they're trying to show who they are, they're misunderstood. So part of the work I do, in the work I'm doing, working with parents and children, is help interpret for one another sort of what the other one is saying. So next slide, please. So this next slide really comes out of a wonderful relationship-based treatment called the Circle of Security. And the piece here that I think is really important to note is that there's really no single interaction that's going to make or break the attachment. It's the pattern, as I said before, the pattern of interaction that determines the quality of the relationship. So part of what we're looking at as clinicians is how to help that pattern be consistent and loving and nurturing on both parts so that the parent and the child can understand one another. Next slide, please. So now I'm going to just mention a few barriers that come up particularly in families where there's substance use or there even when there was substance use, because some of these patterns are not just biological, but they're environmental. So one thing that we do know is that when children bid for interaction or connection with their parent and it's inconsistently met, the child will begin to withdraw. And I think if any of you are familiar with the still face videos by Dr. Ed Tronick, he really does a nice job showing how the child is trying so hard to interact with the parent, and when the parent does not respond in the still face paradigm, the child starts to dysregulate and eventually they give up. And then there's other reasons certainly that happen where that would cause barriers. Next slide, please. In our case, for example, if a child is born substance exposed and they're in the level 2 nursery or in the going through withdrawal period, a parent may be able to be there during the hospital time that they're in the hospital, or they may not. They may need to be going in and out and not necessarily be with their infant. I think certainly when a child, I know in my work, I work at a methadone clinic, and many of the women I'm working with tell me that when their baby was born and they were anticipating that the baby would go through withdrawal, they were feeling so guilty that just in itself, the thought that the child was going to experience some of what they know that they go through when they're having problems with withdrawal, that can be a real barrier, the guilt and the shame. Certainly, I think there's other reasons. There's disruptions as the child is moved out of the hospital. It may not be placed with the parent, or over time it may have multiple placements in different foster families or kinship placement. And depending on the environment that they're going in and out of, it may not, again, like I was saying before, that in order to know someone, you actually have to spend time with them and have experiences with them. And so a parent may not be, like for example, if a child's in foster care and the parent only sees the child once a week for an hour, they don't necessarily know what calms a baby down or what makes a baby anxious or upset. And so part of the work, again, that I do is sort of trying to help think with the parent what the child seems to respond well to, how he shows the parent that he's responding well. Next slide, please. I'm going to actually start with this slide from the bottom up. When parents don't actually have a strong understanding of child development, it can actually really impact the attachment. So, for example, I run a parent group every week, and one of the moms recently who came in with her toddler didn't realize that a new setting, particularly a loud, busy setting, could be kind of overwhelming for a child, and the child would actually use the parent as a secure base. And in this instance, the child got pretty clingy, which is absolutely normal. But because the parent didn't have an understanding that was normal, her understanding of why this child was acting this way wasn't entirely sensitive. And she even attributed it to the little girl being, sort of bratty. And so part of my work, again, is sort of to think with the parent, maybe not in a real direct way, but to say, I wonder if because of all the people in the new setting that she's feeling anxious and she needs you to hold her and even maybe step out because it feels a little bit overwhelming at times. Next slide, please. So when we think about the infant, for example, there's a number of reasons why, again, we're thinking about this dyad both from the mother's perspective but also from the baby. So I'm going to start with the mother. There's a number of reasons why she herself may be preoccupied or not available to sort of focus specifically on her infant. So one of the things, if she's been using during her pregnancy, she may be very anxious that the child is going to go through withdrawal, or in fact there might be something wrong with the child. Certainly there's a very large preoccupation with DCF. In our case, the child welfare system is going to become involved, and at what point, and will they remove the child? And they definitely have a sense of guilt. Many families are sort of finding their way in terms of early recovery, and they may be intoxicated, or in fact, if they're on medicated assisted treatment during their pregnancy, it may have been at a higher dose because of the pregnancy, and they are needing to come down on their dose, so they're not yet stable. There certainly are issues in the relationships that they have all of the time, but if there's difficulties in the relationship with their partner, that might be something that would keep them from focusing on the baby. They may have some ambivalence about being a parent, and they may not have as much social support as they would like, or we would like as providers. And then certainly they're being pulled away from the hospital for a variety of reasons. It may be that they're in residential treatment and they need to get back, or they actually can't stay in the hospital with the baby, or they have to leave to go dose if they're on medicated assisted treatment. And again, this is sort of that back and forth that they're trying to navigate as being new parents. Next slide, please. The newborn, on the other hand, is also managing a lot in the way that they could be born premature, they could have low birth rate. We know children that are pre-exposed in utero often have issues around being very sensitive to light, to sound. They're trying to regulate their bodies, as well as having difficulty with trying to organize their just their ability to suck, to swallow, to sleep. They need a lot of support and soothing around going to sleep, but also coming in from asleep to awake. So any of those transactional or transitioning points. And one of the things that I've noticed in my work in the hospitals is that nurses can be extremely supportive to parents in just sort of showing them how to help babies, how the baby is trying to show the parent that they're overstimulated, or in fact so for example, if they're sitting up, or if they're hiccuping, or if they're looking away, or if they're becoming very fussy, those are all signs that the parent can learn from the child that they're having a hard time and they need less stimulation, or they need more support in certain ways. And again, they're trying to find a way to communicate in their own little way what they need, and they need someone else to be watching them and understanding that communication. Next slide, please. So what we know is that obviously we all do better when we feel supported and we don't feel judged. These parents, all new parents, are anxious and afraid and want to feel like they're doing a good job. And I think, as Dr. Winnicott again said, is, my baby going to be okay, and can I care for my baby? Those are two really just basic things that all parents go through, but certainly parents who have a baby that's born substance exposed. What I've been struck by in my work, both in residential treatment but also in the methadone clinic where I work, is that the judgment actually that comes from one another. And recently there was one of my clients had relapsed, and prior to this she was a part of a core group in our parent group. And I guess I was looking at it from the perspective of, all of these women are going through the similar thing. They're going to have understanding of what this woman's going through, and even empathy. And I think it's partly because of their own fear of relapse themselves, but they in fact were They weren't actually very empathic. They were more judgmental than I expected. But we know, even if they show it in different ways, we know these parents are struggling with guilt and anxiety, and part of our work is to stay calm and to help them find their way. Sometimes I've experienced that when I'm trying to think with a parent about the signs and symptoms that a baby, for example, if a mother is pregnant, and I'm trying to anticipate with the mother what she's going to see if the baby goes through withdrawal, trying to think about what the baby will be going through, but also how the mother could respond. Sometimes just noting all of these different parts can be so anxiety-producing and guilt-inducing that the parent actually can't hear what I'm trying to say. So again, I just remind myself that I need to sometimes it's just showing somebody rather than telling them. Next slide, please. So all of the following things that are listed on this slide actually we know can be difficulties for children and babies who've been substance exposed. Today I'm actually going to focus on the regulation piece, the sensory piece, and I've already mentioned some of the attachment issues. But we also know that, that the other pieces on this slide are like the cognitive part and the feeding difficulties are common. Next slide, please. So self-regulation is very important, partly because a parent who's been using may have been using in part to regulate their own emotion, but also when we stay calm, we help the parent regulate, and then the parent then in turn helps the child regulate. So it's not uncommon for a parent to be dysregulated based on, sort of everything that they're going through. So our presence, our consistent, kind, calm presence has a huge impact. And if you show up every time you see them with that same, despite sort of all the different things that are going on in the setting, that can make a huge difference for these families. Next slide, please. So, and what we do know is that, regulation starts in attachment. And I think a person's ability to learn how to calm themselves, learn how to self-soothe themselves, all comes through the parents working with the child around the arousal system. And it impacts the attention of the child, their child's ability to sleep, not only as an infant, but certainly as they get older. Next slide, please. So how do we actually encourage and help families learn how to regulate their child? So one thing that we know is that you can't control how a baby sucks and swallows, but you can help them control their body movement. So swaddling is huge. Also, I think one of the things that's really important to know is that overstimulation happens in a variety of ways. It can be the light and the sound in the room, or it can also be the movement from back, too much movement. So even in some cases when a baby is sucking and swallowing and digesting their food, that can be overstimulating. So when you think about how many transitions a baby makes, for example, times when you are taking the baby from maybe the foster family in the car to the DCF office to visit the family and then back again, and what type of environment is the child coming into? Is the room, sort of quiet? Is it have, some of the questions you would want to ask yourself is there the light in the room fluorescent, or is it a lamp? Is there a lot of busyness going on in and around the room? So, for example, if you're having a DCF visit, you might want to think about trying to have the visit in the morning rather than the afternoon, because if a child is, all the after-school children are coming in the afternoon, and in the morning it's a little quieter. I think the other thing to know is that infant massage can be incredibly helpful, both during for the parent to understand the baby's response to massage, but also many babies who are born substance exposed have their tone is very tight, and so part of the infant massage helps them relax. But proprioceptive input, as we'll see in the sensory motor section, can really be a way to help regulate a child. And so rubbing their head, massaging their arms and their legs and their body can be very helpful. Next slide, please. I should mention just that some of the work that I'm mentioning here is through a woman at Research Triangle in Chicago. Her name is Cheryl Pratt, and she's an infant mental health specialist. So one of the things that we do know is that when children have structure and their environment, there's different ways that structure can help a child. So one of the ways is that we learn about our relationships is by the relationship happening in the same way over time. And so that certainly happens in infancy, but then as a child gets older, when they go to preschool, for example, or you come in, you have the same routine every day, and that's one of the ways that a child feels like the environment is predictable, it's safe, and they have a sense of time based on just the environment. When we think about families where there's substance use or there had been substance use, many times the structure in a parent's day is organized around the drug use. So getting the drug, using the drug, being in withdrawal from the drug, and the organizing factor is not the child, it's not the structure. So a child's, what would normally be sort of the hallmarks of a day, like your breakfast, lunch, and dinner, for example, that might go out the window. And we know, one of my colleagues says, when they think about growing up in a family where there's, alcoholism or drug addiction, it's a little bit like looking in the mirror at a fun house. You don't know what you're going to get. And that is so true, because the unpredictability of families' interactions when they're using can be anything from, a parent could go into the bathroom and use and come out and be a whole different person. So part of what we're helping the child and the parent sort of understand is how important structure, predictability, consistent limits can be. I think one of the things that I notice a lot is the lack of recognition how transitions for children can be extremely disruptive. And so we mark those transitions in certain ways. So, for example, if you give a heads up, like a 5-minute warning, either by telling them that there's going to be a transition coming, or having a special song that you sing when there's a transition coming. Certainly, I know when I'm with a child and a parent, I often anticipate what the child's going to be going to after they leave my office. Sometimes I'll even do what, with the verbal direction, to sort of help a child transition from one space to another, is to literally walk with them and say, count the number of steps it takes to go from my office to the elevator. Because again, it's a way of sort of marking time, but it helps them move from one space to another. It's very regulating. Next slide, please. So what is co-regulation? An adult saying regulated helps their child to develop the capacity to self-regulate. In the process, each member of the dyad regulates the other. I think, one of the things that I notice is that if a parent is inconsistent and dysregulated and they're working with a child, that breeds, it can go either way. A parent can be dysregulated and a child can stay calm and regulate the parent, but then the parent can be regulated and help a dysregulated child. But when I think of this in my own life, for example, when I get anxious, when I have to prepare for a presentation or I'm doing something, I either call a friend up, or sometimes even just sitting next to someone who's calm can make me feel better. I think the energy of a person actually can make a difference when you're trying to calm down. So again, if you're thinking about the children in this situation, if you can help a parent be calm and feel competent, that's going to in turn help the child feel calm. Next slide, please. So one of the things we know is that sensory processing definitely is impacted in these children, particularly, and you may see it more labeled as ADD or anxiety disorders. But when we think of sensory processing, what we think of is it's the capacity of the central nervous system to integrate information from various senses to enable a person to interact with the world. And so what you might see with many of these children is that they have difficulties in self-regulation, or they're reacting both to their internal stimulus but also their external stimulus. So they could be both hyper and hyposensitive, which causes difficulties, obviously, in their development because they're preoccupied, but it can also lead to difficulties in their relationships. They may have difficulties in adapting to new situations, and some children are actually more sensory seeking than others. And one of the things that I know that when I'm seeing a child really needing a lot of sensory input, in my work at the mental health clinic where I work, I might see a child go instantly to the sand table and they need that sort of sensory input, or there's ways in which they become more organized if you help them with their sensory, the aspect of their sensory parts of themselves. So OT can be very helpful in these situations. Next slide, please. Some of this I've already mentioned before, but I think one of the things we always want to be thinking about is the environment that the child is going into. So is it overstimulating both? So for example, if you go to a child care center that's bright and colorful and full of all the bells and whistles, is that going to be overstimulating? If a child goes to the mall with the parent, is that overstimulating? I think, so how does the child respond in that environment, and helping the parent understand that? One of the things that I noticed, for example, when I worked in residential treatment programs, is a parent and a child reunifies at the residential treatment program. So they're meeting up with one another. They haven't seen each other. They come into this new environment. The parent's dysregulated because if she's being asked to for a variety of demands are placed on her. And then the child is also overstimulated, and maybe the parent's not able to attend to their needs. So part of, if a provider understands this, one of the things that they can really do is to sort of help orient the parent and the child, recognize if the environments they're going in and out of are overstimulating, help the parent understand how to calm down the child, providing, different ways that they can have a sensory diet. So either having an OT doing an evaluation, or if somebody recognizes the child's dysregulated, providing different types of equipment like soft bean bags, having soft lighting, soft pillows, fidgety toys, chewy toys. One of the ways we often regulate ourselves is to chew on things. Frequently, the children that I see, even as they get into the toddler age, are still sort of mouthing things or chewing on their hands, and that's usually a key signal to me that they're overstimulated. Next slide, please. So I think I've already mentioned some of this. One of the things that I've found very helpful for older kids is that the space that you go into, if it's too open, it's actually not helpful. It needs to be marked by boundaries. And in addition to that, sometimes we can actually anticipate with a child through labeling things. Like, so if you have a calendar, it could be a visual calendar where you say, well, you're here with mommy and me, and we're at our house now, and then we're going to go to school, and you could have a visual picture of a school, and then we're going to go here, and again, another visual picture of that. Children really need to know where they're going to be, who they're going to be with, and how long they're going to stay there. That's some of the things that help us feel safe and secure. Next slide, please. So again, I think I mentioned some of this already, but transitions can be extremely difficult for these families and these children. So some of the ways to really help is to anticipate with a child and a parent that there's a transition coming. I had an experience not that long ago. I went to the park with a parent and a child, and the child's going to be 2 next month. And I was saying to the mom, well, we're going to get going. We're going to need to leave in about 5-10 minutes. And the mom said to me, oh, my daughter's going to freak out. She loves being here. She's going to freak out. And I said, well, I think one of the things we could do is to just let her know we're going to be leaving and do sort of a countdown. But then we also want to say goodbye to all the different things that are at the park. So, kind of like the goodbye book, but the goodbye song. You say, 5, 4, 3, 2, 1 minutes left. You say goodbye to all the different swings and slides. And the mom was extremely amazed that this actually worked and the child wasn't just completely having a total meltdown. So what I took away from that experience was that even something simple as helping a parent with transitions, something I took for granted, a parent may not necessarily know, and it can be really helpful. In the parent group I run, I always try to run it. I start with the same thing, I end with the same thing. So another thing you can do around helping children regulate, and this could be at transitional times or it could be just in general, is to have an activity that has a beginning and an end. So for example, puzzles have a beginning and an end. Putting all the beads on a string, that has a beginning and an end. It allows children to feel more in control. I think, and also just recognizing that at the beginning of a relationship with a parent and a child, when the transitions haven't been established and you haven't already sang the song a million times and you haven't done it a certain way, initially it's going to be a little more chaotic. But as you go through it over and over, the repetition, I think, is really very anxiety relieving. Next slide, please. So the next slide, I think what we know is that behavioral problems are a part of this population. And I attribute it primarily to the lack of self-regulation that's been internalized. And so if you go back to that earlier time and really help them regulate, some of these parts will actually go away or become much more manageable. And also the child over time will learn both that you understand them and they'll start to recognize ways to calm and regulate themselves. So I'm going to now turn it over to Karen. Thank you so much.
I'm going to pick up from where Beth left off to talk about first child-parent psychotherapy, or as I refer to it as CPP, and reflective functioning. And starting off with CPP, this is authored by Alicia Lieberman and Patricia Van Horn from the University of San Francisco. It is an evidence-based treatment. One of the things I like to say about this is that they call it a curriculum, but in fact that can be a little deceiving in that it's not even though it's manualized, it really is a practice of psychotherapy. And what I also want to say is that today, from this presentation, Obviously, the point is not that you're going to walk away knowing how to do child-parent psychotherapy that has a lot of fidelity tools, but for you to really understand the principles of CPP, many of which Beth have already spoken about. Next slide, please. So child-parent psychotherapy, it's a relationship-based treatment for children birth to 7 who have been exposed to family violence. So this is how the authors have written it. We here, one of the things that we've done in our project is that we have adapted child-parent psychotherapy to including substance use, parental substance use. Other thing that we have done is that the authors didn't work, even though they said that they worked with children birth to 7, we also included parents, moms that were pregnant. And I get just a lot of excitement and joy out of that there is actually an intervention to, as Beth talked about, to anticipate what better time to intervene with a woman who has had circumstances in her life, and here she is getting ready to bring a child into the world and to even have an opportunity of being pregnant. And so that's another way that we have adapted. So looking at the premises of CPP, as Beth talked about attachment, well, in fact, CPP is an attachment-based system of organizing this kind of psychotherapy. And we know that the attachment system is the main organizer of the children's response to danger and safety in the first 5 years of life. We also know that emotional and behavioral problems in infancy and early childhood need to be addressed in the context of the primary attachment relationships, hence why we're doing CPP. I also want to say, although it goes without saying, that when we talk about parent, caregiver, we are talking about all caregivers. We're talking about fathers, we're talking about grandparents, aunts, kinship placements, foster homes. So please know when I use the word parent or caregiver, I'm including everyone. And that one of the things that we know about CPP and the reason why we're doing this work earlier and earlier is that the more you can promote growth in the caregiver-child relationship, and the earlier that you do this, this supports healthy development of the child long after the intervention ends. The hope that we always have, and the goal that we always have with CPP is that the earlier the better. We know that that's good for the brain. Well, we also know it's good for the relationship. It's good for the attachment between the child and the caregiver, and that this child, might not need treatment long after it's, growing up and in school. And so this is a new approach in terms of people never thought of thinking about psychotherapy with, babies. That's just not something that was considered. Next slide, please. So CPP, we always consider that the parent and the child dyad, no matter who is in the room with you, that's who I'm keeping in mind. So sometimes it's in fact true. The baby might be in the room, but the baby could be sleeping. The child might not be in the room, and that this mom is having undivided attention with me. But when I'm doing that session, I am still holding in mind that the dyad is who I'm working with. The whole point of CPP is building a trusting relationship, as in most treatment, all treatments, and it's also repairing the conflict over and over again. There isn't just one conflict, right? I mean, every day there are conflicts, every moment there are conflict. And so that repair is happening moment to moment to moment. And we're aiding the parent and the child just to engage with each other, to be interested in each other. I've had many parents when starting CPP think that, this isn't so difficult. If the baby is, calmed down, then all I really need to do is change the baby and feed the baby, and the baby goes to sleep. And that we know that it's much more complicated, and through the process of CPP, that comes out. And if there's one thing that you take from CPP is that we really want those caregivers, those parents, to have the opportunities of shared joy, of being curious, of looking at their child as a separate human being and wondering about them. And we have to remember that, yes, this all might sound pretty simplistic, but we are talking about parents that have used substances not because they have chosen to. Nobody in life goes out and says, I'm going to be a substance user. But they got there because of trauma that has impacted them from a long time ago, nurturing that perhaps wasn't there, neglect, so many different possible, issues from their past. And so this is not something that necessarily they ever experienced, with somebody truly being curious about them. So that's why I really like to highlight that point. Next slide, please. You, me, and the relationship. And that is the focus of CPP. It's the play and the caregiver interaction. That's what we're doing there. I already said, it's the dyad who's the client. I value the experience of the caregiver and the child. They're equally valued. You know how we can get into, or it used to be that when you worked with children of all ages, that the provider could sometimes weigh on the scale of blaming the parent. And in CPP and in all treatment, we have to work extremely hard knowing that there are shared stories, there are separate stories. And the more I understand the story of the parent or the caregiver, the more I'm going to understand that baby. And the more interest and curiosity I show about the parent, it's what Beth talked about before. It's a trickle down. The more interested I am, the more interested they're going to be in their own child, with their own child, without me saying, oh, it's really important for you to be interested in your child. That would not be a concept of CPP. We don't tell people what to do. Hopefully it's based on how we behave and how we ask questions. We are, and it's an honor to have the capacity to act as the conduit or the translator between the parent and the child's experience. And I also want to say about that is that we also are just always thinking about attunement and how to improve attunement. Again, it's that notion of the more attuned I am to the parent, or the more the parent sees me being attuned and interested in the baby, that parent is going to increase their attunement also. So one of the things that CPP offers, and it's a good visual, and it's something that can be held in mind when you're doing this dyadic work. And it's not even something that you have to say, oh, I'm doing CPP, so I have to keep these lenses in mind. But what we're always thinking about is the safety lens, the attachment lens, the developmental lens, and the trauma lens. Most importantly, in the center of the lens is that we're always paying attention to the family's cultural norms and values. Research says, and I actually believe by practice, is that if you notice the differences and you talk about the differences in the room, then you're going to be that much more transparent. And again, talking and putting into words things that sometimes people are uncomfortable in talking about. So, I had the example of a number of years ago working at a large teaching hospital, and they had different cultural teams. They had a Haitian team, and they had a Latina team. And the assumption, so this was many years ago, well, of course, all of the Haitian community, they're going to want to be seen at the Haitian clinic where there were Haitian psychotherapists. And of course, this just made a great deal of sense, and everyone felt so excited and proud about this. Well, what we learned is that, yes, first of all, you can't make a generalization about anyone. That's always dangerous, right? But it came to be that I had a number of Haitian clients that chose to come and see me and my colleagues, and we were not in the Haitian clinic. And so when I just talked about that and they noticed and mentioned about that, they said, first of all, it's way too small of a community. Second of all, I want a different perspective. Third of all, I'm living in America. I already see that there are different rules here, like with the Department of Child and Family Services, our child welfare system. So, making this assumption that they would want to see somebody Haitian was actually incorrect, and that never making those kinds of assumptions. But during our psychotherapy, and I was seeing that mom and dad and young child, I had such an opportunity of learning about the Haitian culture, and they had the same way of learning from me, and I believe it was a much richer psychotherapy. Next, I also want to say that no matter what intervention you choose or what port of entry or what lens you choose to look at, you always want to make sure you're looking at what the impact is going to be on both people in the dyad. So we talked a lot about the attachment lens. I like to think of the attachment lens as, here is our goal. Here's our goal where we're working together. Grow well, love well, and understand each other. Yes, help regulate emotions and recover from dysregulation, repairing those conflicts over and over again. Again, that joint joy of exploration and learning together. One of the things that clients have reported about the project, and one of the reasons that we did not have difficulty getting people to engage and sign up to be in CPP at the methadone clinics and in residential treatment was the word got out, so to speak. The word came out that there was very nice people, mostly women, but very nice people that were just interested in meeting with you to talk about you and your baby, to play with you, and that they had just never, that was not typical of their usual treatment, and definitely not typical of their usual substance use treatment. And they became curious about, well, why would anyone just want to be interested in that? And word got out that it was actually that the meetings were enjoyable. And so I felt like that was just such a powerful thing for us to learn. Next slide, please. Thank you. So the trauma lens, it's an opportunity to construct a joint trauma narrative. Now I say that, and then I also want to say to you, it's not absolutely necessary. And this is obviously coming out in the literature, that people have to go through their narrative of their trauma. So when I say that about constructing a joint trauma narrative, what I want to make sure is that the client knows that I'm trauma sensitive, that this is a trauma-informed organization, that CPP is a trauma-informed psychotherapy, but that does not mean that people need to tell their story, but it comes in with an understanding that I know things that have happened to them. They come into a session understanding that I understand that where their substance use and co-occurring disorders have come from. Being trauma-informed means you never ask somebody what is wrong with them, but rather what has happened to them. And many, many people who have experienced trauma from being a young child, and perhaps even somebody who's experiencing trauma as they sit in the room with me, say that kind of question is absolutely without judgment and with an understanding that we understand that things have happened to them. I think the other thing about the trauma lens that is so important to remember, especially in this kind of dyadic treatment, is that when you're sitting in a room with a parent or caregiver and a child or baby, is that oftentimes it's that parent or caregiver who has been the source of trauma. That's very complicated. I've talked about that before, about the shame and the guilt, but what can actually happen is that the child and the parent can, if you will, trigger each other and be traumatic reminders to each other. So this is something that we can put into words. This is a concept that we can talk about. So next slide, please. Developmental lens. We want to provide developmental guidance. We want to help the parent understand what's going on. Well, you might say, well, that's really easy to do. We can just sort of teach developmental milestones 101. But we know that we're not there to teach. We're there for them to come up with their own information or from being curious and wondering. And so this is, and I'm going to be getting soon to reflective functioning, but the more curious I am, the more curious they become. That's just a very simplistic way of saying it. So one example was that, in fact, Beth and I were visiting a residential treatment center. This was a few years ago. Beth was introducing me to one of her clients. It was dinner time. The toddler was in his high chair, and it looked like dinner was about over for him. And how did we know dinner was about over? Is that he started pitching his food overboard. Now, we've all seen that, right? And he thought this was great because what fun to, drop that food over ground. And also, guess what? He caught both of our attention while we were talking. So here were three adults, and we were sort of talking, and we probably weren't paying as much attention to him, but he let us know that it was time to pay attention to him. Well, somebody bent over, I believe the parent picked up the mom. She put the food back on the tray. Well, of course, you know exactly what happened. But what came out of that was that later on, the mom, you could tell, got dysregulated from this. She was unhappy with the child, and we, Beth and I knew at that moment, is that she really did not understand. She did not have that developmental information that when a child throws their food overboard, why do they do it? They're full, they're tired of sitting, they're playing, and they're finding a way to attach and to connect. It's just, all those reasons. But what she said to Beth was, remember how I told you that my child was evil? See, that was one example. And in fact, of course, that's startling to hear. But if Beth had just stopped and said, no, your child wasn't being evil, but really unpacked what it meant to her. And so the reason why I like to bring this example is it would be just so simple to say, well, developmentally, what your child is doing is A, B, and C, and that's what Beth got to. And so she had that understanding. But CPP sometimes requires a little bit slower of a pace and timing because you want to have them help unpack this. I'm curious, where do you think that you learned that from? And again, oftentimes this has come from earlier experiences. Next slide, please. So the safety lens is obviously incredibly important. One of the things is that we're there to help the caregiver provide physical safety. We're there to model protection when needed. We're there to help the caregiver provide emotional safety, and we're there to provide emotional safety to the parent, so in turn they can do it to their young child. One of the things that sometimes can happen, and happened to me once, is that I never want to be the expert in the room. I am never going to be the child's parent. We want to enlist the parent to be the expert and to obviously keep that relationship getting stronger and stronger. But one time, and sometimes this happens, this was a toddler, there was something in the room, and there was a pole. So this was not something that could be removed, and he started climbing up the pole. Well, I observed that the mom was not getting up off the floor. We do a lot of CPP on the floor, by the way. Or it's a very popular place. What better way to interact and be on the same level as the child? How important is that? But this little child was not going to stop. The mom was not going to necessarily get up in the timeliness that I saw fit, and I felt responsible for the child's safety. So unlike most times, I went up, took the child down, and then what I did was get into a conversation with the mom about why did what were her thoughts about why I did what I did? Instead of saying, well, Mom, you really should have gotten up because your child was in an unsafe position, how much more lasting, how much more respect, how much more is that kind of intervention with respect and non-judgment, but wondering with the mom what it was that she was thinking, wondering out loud, am I somebody that can be overly cautious, which sometimes I can be, and really looking at all of these things in the room at the same time. Next lens, please. So what I would like for you to take from this is that using child-parent psychotherapy principles, much of what we've already talked about, and highlighting some of them, so you're going to know, and probably you folks already do a number of these things without knowing that some of these were principles of child-parent psychotherapy, is wonder why a young child might be behaving in a particular way. Helping mom learn about her child's likes and dislikes. Even helping her understand that a baby, you can help understand a baby's likes and dislikes. Help a distressed mom calm down so she can calm her baby and her distressed baby. Sit with a mom just to observe her baby, but doing it together. Support a mom and child to play together or to share a positive moment. Something that we've definitely learned from this, and I think you'll see a quote later on, is that you can't assume that these moms or caregivers, fathers, that they experienced a caregiver playing with them. Next slide, please. So this is my introduction to reflective function, and I really like this slide because it really shows how listening is more than just listening. I have a little story for you about this. There was a little girl that wanted to show a picture that she drew to her mother. The mom did not change her focus from what she was cooking, and the little girl repeatedly saying, Mommy, Mommy, guess what? What? The mommy said. Mommy, Mommy, you're not listening. Mommy said, oh, no, I'm listening. Mommy, you're not listening. This went back and forth, and mom insisted, I am listening. And then finally the little girl said, but Mommy, you're not listening with your eyes. So we know how important eye contact is. We know how just in the sessions, having the mom look at the baby, and then what happens to the mom or the caregiver when the baby looks back, and us commenting on what we see. Oh, look when Zach looks in your eyes. Look how happy, and look how much he calmed down. And just that is also that's a teaching moment without you being the teacher. But we're also always trying to listen with more of our heart, as much as with our mind and our other senses. Next slide, please. So I like to think as the healthy attachment process boils down to just really good, in-depth, constant detective work. Because really, isn't that what we do when we're caring for a baby, a toddler, or a child? What is it they're trying to tell me? Especially, of course, when they're preverbal. And so it is this notion that children that are preverbal, that we talk to them even though they can't talk back to us. And so we are always trying to read their cues. And, of course, we miscue all the time. And that's part of what happens in the developmental lens of that shared understanding that we can't always get it right. But it's that pattern that Beth talked about before. It's that pattern of interaction, and therefore the child understanding your positive intent even when you miscue. I had the experience of having two children at one point that were, 2 years apart. And the younger one, I really had a hard time understanding him. He was speaking, but I really had a harder time understanding his language, and he had a little bit of a delay. And my 2-year-old at the time understood every single thing that he wanted, every single thing. And she would sometimes say to me, but Mommy, don't you understand? He just wants that cracker over there. Or he doesn't like it that his cracker was broken. And she then became, of course, my translator, so I could help my younger child. And it's something that we all joke about, but it was really true that she had this relationship, and she was a little bit better, a more effective detective than I was in that instance. The other thing I want to say to you about this is that it's really important that you watch your baby or your child to identify 6 states. There's the active alert state, there's the crying state, there's that drowsy state, and that drowsy state comes before that light sleep state, and then the last state is that quiet, calm, and alert state. That's only 10% of the 24 hours that a baby spends in that quiet, alert state. What I find interesting, and I'm sure we all know this, that's the time that you want to rush off and just, while the baby is quiet, alert, but safe, run down and put in a load of laundry. Or, I'm just going to take something out of the freezer or defrost it. Oh, I might even get the baby to sit in his little, carrier, and I'm going to get my shower in even though it's 3 o'clock in the afternoon. And what's so interesting about this is exactly the state that you want to, this is what they call the premier state, because that's when you want to be engaging with your young child. And we know that that's not always possible, but it is that time where the baby really, really gets a lot out of the interaction. Next. So this is from Arietta Slade, and she talks about maintaining a reflective stance, and how you do that is through mentalization. And so I want to read this quote to you. The heart of good mentalizing is not so much the capacity to always accurately read one's own or another's inner states, but rather a way of approaching relationships that reflect an exception, that one's own thinking and feeling may be enlightened, enriched, and changed by learning about the mental states of other people. Next slide, please. Alicia Lieberman, one of the authors that I mentioned before about CPP, she likes to say that child-parent psychotherapy talks about the reflective capacity as respectful inquisitiveness. So that's what we're doing. We're always respectful without judgment, but we're very inquisitive. We're very, very curious. I want to highlight on this slide the second bullet, that researchers have consistently documented that mothers, caregivers, parents who are able to reflect upon their own and their child's feelings, intentions, thoughts, and desires are more likely to have secure children. And this is constantly with the background in your head and who you're sitting with, knowing that many of these folks did not have the same opportunity. This is new. This is new. I had one mom say to me, this was last year, I was working with she and her toddler. She had experienced a lot of trauma, and she said to me, she also was a substance user, and she said to me, why do you ask me so many questions? You can't possibly be that interested in me. And she was completely serious, and we had a big conversation about why I was interested in her, what it meant to be interested, what it really means. How do you show that you're interested and you're curious about someone else? Really, one of those conversations that you just want to have happen. Next slide, please. So you can read some of the strategies for enhancing reflective functioning, some of which I have definitely already mentioned. I want to give you some examples, though. While you're reading that, I will give you some examples from Peter Fonagy, who highlights the importance of using the first person, I statements, and putting that voice in, and how that helps maintain a reflective stance, or taking that mentalization and keeping it in the room. So this would be an example of a provider of, I take a stance of not knowing what the mother or the baby's experience is, and I'm interested in finding out. So I say, tell me more. I'd like to understand what it's like for you and what you were thinking or feeling at that moment. That stance of not knowing is a powerful one. I don't know if you've ever had this experience, but you go to someone to get an answer. Oftentimes we go to doctors, people come to us as providers around behavioral health issues and relationship issues, and they're expecting answers. And the not knowing from a provider is just as powerful as knowing. Because in fact, we are not all knowing beings. We're there to help them discover what they know. So another one of those examples is I pay attention to the times the mother can consider alternative perspectives. Try to elaborate on these moments. The example here is, it seems as though you were wondering if his cry meant he was really hungry, or did it mean that he was trying to tell you something else? What else do you think the crying meant right then? What else sometimes does the crying mean at other times? So those there are many, many, many of those, but that's a way of positioning yourself and taking a reflective stance. Next slide, please. So before, when I was saying to you that we're the conduit or we can be the translator, what ultimately we want to have happen is that the parent becomes the translator. Sometimes what needs to happen first is that we need to do some of the translating. So we want to translate to the parent and the child's meaning for one another to foster a mutual understanding, trust, and empathy. Sometimes we speak for the baby. Sometimes we speak for the baby. Alexander Harrison, a psychiatrist in Boston area, oftentimes when I see her present, she takes on a completely different voice in play therapy with children because she says it's important for the children to know that that voice is not actually her speaking. I know that sounds confusing, but that voice is perhaps her saying the words and wondering if that's what the child is thinking. This is actually a technique that's taken out of psychodrama. We're there to observe cues and miscues, also being complete forthright in us missing cues and miscues. The best times in sessions are when the parent says, "Oh, no, Karen. In fact, this is what Zach is telling me." Encourage that reflective developmental guidance. One of the things that I want to say is that people have, I think we're understanding more and more, but people do have sometimes a misunderstanding around that children, babies can't speak. And we aren't clear exactly what babies hear in terms of words and language, but what we know is that they recognize your voice. So this is the opportunity to reflect in CPP of speaking for the child or thinking that you know what the child might want, or then you saying to the mom, and really encouraging the mom to narrate for the child. So, when you are changing a baby's diaper, they might get dysregulated. You might hear someone say, okay, I hear you. I know you don't like this. Oh, it might be a little chilly. Here, let me put a blanket on you. And, you go through every single detail. It's almost like how Beth was talking about the transitions. But it's that hearing your voice. That's how language is learned. And so it's that narrating your life together, and the parent learning how to narrate their life for their child. The assumption is always they're too young to understand, which is absolutely not true. Next slide, please.
Karen, I just wanted to let you know that we have about 20 minutes left, and we want to save a little bit of time for a few questions.
Okay, so I think what I'll do, I think I'm going to add it's a perfect time to end with these quotes from people that participated in about 9 months of not every single week CPP. And so these were some, and we have many of these, but these are some that I just picked out. One quote: "I'm so much more aware of this child because I was high when my older when my older kids were little." The next one: "I've learned how my relationship with my daughter is a template for her relationships with other people." The next slide. I kind of feel the change in me and my son. I don't know, just feel more closer to him. Before, I didn't feel that close because, I don't know, I was like, oh my God, he's a pain in the butt. Oh my God, he doesn't want to sleep in his own bed. And now it's like he doesn't want to sleep in his own bed because he loves me. He wants to be close to me. So before it was all about the complaining, and like now it's all about being grateful. So I think that's a perfect way of ending.
Thank you so much, Karen and Beth. We do have a few questions, and I will get started with reading those, and you can decide who wants to answer. We did have a few questions that came in about the sensory diet. What are some examples of a sensory diet?
So an example for that would be if a child needs to have more pressure, if he's sitting, they could put a weighted vest on him. He might use fidgety toys, so these would be balls, for example, that you can squeeze, or they have prickles on them for their fingers. Another one would be trampolines, or it could be like those big rubber balls that you roll on. If you go to an OT occupational therapist, they'll have many of these different types, and they'll figure out based on an evaluation if the child needs more input or less input.
So to be clear, a sensory diet isn't actually food, it's more of an array of services that they refer to as a sensory diet.
Exactly. It's for their sensory input, so there's different senses.
Okay, great. The next question, can you recommend some good books for staff to use when facilitating attachment in parents and children?
Well, I think the book that Karen referred to, I mean, if it's are you saying it's for the provider to read to know how to work on the attachment system, or is it more to work with the parent and child?
For the provider.
Okay. So the book that Karen was referring to by Alicia Lieberman, she's written a couple of books. One is called Don't Hit Your Mommy, or Don't Hit My Mommy. The other one she wrote that's more of a comprehensive guide is called Psychotherapy in the Young Child. That's certainly a really good book. The Circle of Security folks who I mentioned earlier, they recently came out with a new book. I don't recall the title, but if you just went to the Circle of Security website, you could pull it up.
And I want to say about the Circle of Security book, it is extremely user-friendly. So not only do the providers find it helpful, but the providers find it helpful to really bring into the sessions. I also want to say that on YouTube, I've had from training and some feedback from some other clinicians that I supervise, that on YouTube, public domain, a Circle of Security has a few vignettes of what the Circle of Security does. But it also, in those few moments, they're teaching about attachment. And I've had a number of providers tell me that they bring up on their computer this video, this animated, engaging video that really starts the discussion with the client while the child's in the room about basic attachment issues.
Great, that's great advice. Thank you. Another question came in. I am a nurse with DCF. Are the techniques, infant massage, countdown, etc., appropriate for me to discuss with parents/foster parents, or is this something that needs a doctor or therapist recommendation?
I think it's absolutely appropriate. I know in our state, the foster families who are receiving the children who, for example, are coming right from the hospital, we've had a request recently even saying, they needed more support around knowing how to regulate these little ones. So the more information that you can give them, both to understand sort of what's going on with them biologically, but also then how to respond to them, I think would be absolutely appropriate. I also think if you, think with a parent about what they know and what they would like to know more about, or areas where they just feel like they don't really know how to respond to a child, you can figure out what is needed based on those types of conversations.
Okay, someone asked, how can some of our families get CPP or access to resources for CPP?
I would suggest to go actually to Alicia Lieberman, who's at the University of San Francisco. She would be a place to start, and I think depending on the community you're living in, they will have, you know, different providers trained in CPP.
One of the things that's happening around the country with CPP, there are these learning communities and learning collaboratives where there is a certified child-parent psychotherapy trainer, and they have monthly calls, and there is a small group, and people present cases, and they talk about, you know, using CPP, and they meet, you know, virtually on the telephone. And so CPP is spreading around, and so if you can even find out from, and I believe that they have a website, that they would have identified where those, who has participated in those learning collaboratives.
Okay, can you talk about the specific adaptations you made to CPP for substance-affected families, and how does that impact fidelity to the CPP model?
That's a wonderful question. So one of the things that we did initially was to look at, for example, when we started working with pregnant moms, that was an adaptation that we made. We also understood that in this type of work that we were doing, the length of time that we were going to be working with families was going to be much shorter. So that's another adaptation that we made.
We also took it into the home. I mean, you're not always have circumstances where you're doing outpatient therapy. So we took it into residential treatment. We took it directly into clinics, and we took it into home visits, or for that matter, places in the community that were safe. So that was another adaptation that we made. And most importantly is that they understood that we got substance use. And so that even though it comes with a great deal of shame and guilt, is that they understood that we understood how it came to be that they were substance users. And so this was definitely something that was different, because they would report this isn't like substance use counseling, because I think that they were expecting, like, you know, you've got to stop using. You have to stop using. Opposed to, you know, more around the questions of, why do you think it was that you were using? What's it like not to be using and now having a young children? And we know that people, the biggest motivating factor about going into recovery is when someone is pregnant.
Okay, next question. Can you speak to a family situation where the primary caregiver is the mom and the dad is an occasional or surprise visitor who may raise anxiety during his visits?
I feel like you just described most of my caseload. Oftentimes, for whatever reason, it could be that father's going in and out of jail. It could be that, you know, the parents have broken up, or they're not even married. They could have different providers, different fathers in the family. I often will hear the dilemma the mother is holding of, how do I allow this father to be in the child's life when he's so disruptive in my life? And I've also even heard a mother say to me that she didn't actually want to leave a violent situation, because she felt like even though it was hard and scary for her and her child, she felt like she still wanted this child to have access to her dad. So I think a lot with parents about sort of, if the father isn't there, how much you want to say, what story you want to hold for this child, how can you manage your own feelings about the parent without putting that onto the child. For example, if a child only sees his one parent once in a while, and they go to the visit and then they come back and they're very dysregulated, helping the other parent understand why that might be. So again, just trying to be a translator, as Karen said, for this child's experience.
I think also I've had the experience, and sometimes it's not, it's counterintuitive. I had a situation where when the father came for a visit to the home, the child seemed to get even more dysregulated. One of the things that the mom was able to come up with, and after having a lot of these situations, finding like the library where there are other parents and other children and books. So the focus became the activity, so maybe the father reading the child's book while the mother was holding the baby, and having those other folks around, we found, was actually more regulating for the child. So sometimes you would think, oh no, that'd be overstimulating, but in fact, having the father come into the personal space. So, I'm not saying, oh, well, that's the end-all, be-all, that's the answer, but it just requires thinking a little bit outside of the box with the mom. Should the mom be holding the child? If it's always a surprise visit, then narrating, oh, Daddy came for a visit. Mommy didn't know Daddy was coming for a visit. That means you, Zach, didn't know that Daddy was coming for a visit. It's okay. Daddy will stay for a few minutes. What should we do while Daddy's here? Should we all have a cookie and a glass of milk? It's something, where you're narrating because you're going to, without you saying to the father, well, I'm going to calm Zach down because you're being so disruptive. Whatever that mom can do, reading the baby's cues or the child's cues, keeping him closer by, turning on some music. So once again, it's not this intense eye contact.
Okay, couple more questions. Since some of our parents are working on reunification, I wanted to ask if either presenter can provide suggestions for activities that other adults in the home, i.e. grandparents, aunts, uncles, can do to help build or reinforce the attachments between the parent and the child.
So I think any type of activity that you do where, first of all, like Karen was saying, that there's fun, but also there's turn-taking involved. So, in a real basic, simple way, like blowing bubbles can be really fun. Playing with Play-Doh, or I think activities, depending on how long your visit's going to be. For example, if it's an hour visit, you'd want to have time to do something together, but it wouldn't create so much chaos that, you couldn't go in and come out again. But again, I think you want to have parameters so it's not overstimulating. Also, I think one thing that's really important to know is that when children have a lot of fun, for example, if you go to the zoo or you go to a circus, actually that can be just as overstimulating as if just knowing that a child could get very dysregulated during a fun event as well as a difficult event. So again, just anticipating that with the child and the parent.
I think also it's important that since the biological parent is not always going to be present because you're working towards a reunification, that whomever is taking care of the child, who is the primary caretaker, understand that it is okay to talk about mommy. In fact, that is important. Keeping mommy in the room, even when mommy is not there, is very, very important. Oh, and in 2 days, do you know that you're going to be having a visit with mommy? Remember the last time we visited with mommy? And the important thing here is you constantly sort of feel like you're talking to yourself when you're talking with young children, but you know that the receptive language, of course, kicks in way before expressive language. And they're hearing you and they're hearing those key words of mommy. So keeping that mommy in mind and helping that child and the calendar together and think, oh, mommy's coming tomorrow. Well, that's in many hours. What activity do you do with mommy? Oh, should we do this or should we do that?
Okay. How do you help parents want to self-regulate?
How do you help parents self-regulate?
How do you help them want to self-regulate?
Oh, that's a great question too. Well, I think part of what substance use does is actually it regulates parents, one direction or another. So when they're in early recovery or even in later in recovery, you know, part of what you're thinking with them about is when they feel the most calm and when they feel happiest. And, you know, thinking with them, like Karen said, in a reflective way, what types of circumstances were those and what could you do to, you know, so you may be even reflecting on, wow, it seems like when you're calmer, your baby's calmer, or it could be, it sounds like, you know, you feel better in those situations when you're calmer. Just sort of, again, it's in the relationship with the parent, but then also wondering with them what works and what doesn't.
I think also we're making an assumption that they even know what it means to self-regulate. You know, that their experience of life and what they lived through, most likely, if they've ended up turning to substances, as Beth said, the substance has become the regulator. So even that first round of a conversation of that they actually have the capacity and the capability, if they want and if they choose, that they can start to begin to self-regulate. You know, the breath, we're talking very basic meditation tapes, just work the breath in and out, you know, counting 1, 2, 3, 4, or 1, 2, 3, 4. And that is a form of regulation. But I do think it is such an important question, and I think also I would just advise or remember it takes time.
Okay, last question. Should CPP be only done individually with a family, or could it be used in a group format?
So in my experience, the more people you have in the room, the more complicated it becomes because you're holding so many people in mind. I think if you did it in a group, you would actually do more of the principles rather than the actual treatment. So, you know, rather than going back and forth, it seems, you know, pointing out where the parent really is, that, you know, for example, your baby seems to be loving looking at you. Look how much he lights up when he looks at your face. That wouldn't necessarily be appropriate in a group, but you could say, you know, thinking about the behavior of a child. All children show us how they're feeling with their behavior, or children, it's a dyad. We're not in a vacuum. We operate in relationship with other people. So helping them know that their child's trying to show them with their behavior how they're feeling and what they're thinking.
I think if you refer back to the page that seems simplistic, the tips, not the tips, you know, you're using the principles of CPP when, ... So if a mom has to leave the group room, let's say because the baby's dysregulated, one would hope that in the group that Beth would have already mirrored this, or that there would be an understanding that, you know, for the mom to crouch down, to get on the child's level, to speak in a soft voice. So you're, by whatever you're doing in the group, you're demonstrating those principles.
Unfortunately, we are going to have to wrap it up. I'm sorry that we couldn't get to all of the questions. This was a very interesting presentation. Karen and Beth, thank you so much for speaking with us today. I would also like to thank all of the participants on today's call. We greatly value the feedback of everyone participating in these webinars. The link for a brief online evaluation form will appear shortly. Please take a few moments now to complete the form, and it will automatically be sent back to us. We would like to receive feedback from everyone, so if you're joining in this call as part of a group, please be sure that each member of your party receives this link. If you need a certificate of participation, please contact Amanda Hopping-Wynn at HOPPINGWINN@berkeley.edu. For those of you who are interested, our last webinar in this series, Shame, Guilt, and Fear, Understanding and Working with the Complex Feelings of Mothers of Substance-Exposed Newborns, with Etta Spielman and Amy Sommer, is scheduled for June 9th. You can find more information about the rest of our 2015 series on our website, aia.berkeley.edu. Thank you again.